Hi, everyone. Thank you for coming to our didactic. We'll go ahead and get started now. My name is Diane Bongiorno. I'm one of the PGY4s at the Hammer program at Mass General Brigham and excited to be presenting with Dr. Jennifer Love, who's assistant professor at Mount Sinai. And we're presenting the top articles in gender equity in emergency medicine from 2024. So as we know, there's challenges in pay equity, advancement, scholarly activity, and parental leave policies for women in academic emergency medicine. But at the same time, there's a lot of great work being done in these areas. And so the goal of this session is to highlight some of the literature on these topics and also hopefully come away with strategies to improve gender equity in our own departments. We have no financial relations to disclose, and the learning objectives, as mentioned, to hopefully come away with some of these strategies as well. In terms of our process, we conducted a literature review using Medline that incorporated controlled vocabulary and free text synonyms for concepts related to female physicians and gender bias in emergency medicine. We manually searched also the titles of articles from Annals of Emergency Medicine and Academic Emergency Medicine from 2024. And the identified studies were then screened using the Covenant Systematic Review software. Ultimately, we screened 151 articles. Our team then reviewed the 17 that were deemed to be most relevant. We ranked our top 7 and arrived at a consensus of the top 5 that we'll share with you today. The first 2 articles relate to residents in emergency medicine. The first article is on the association of gender and personal choices with salaries of new emergency medicine graduates. So there are prior studies that document gender disparities in emergency physician salaries. However, there's limited research investigating the reasons for these disparities. So the objective of this study was to investigate individual physician characteristics, including sex and educational background, together with individual preferences of graduating emergency physicians and their association with the salary of their first job after residency. The authors sent a survey to nearly 2,200 graduating EM residents for the year 2019, and they collected respondents' demographic characteristics, their educational background, and their perspectives on factors that influence their first job post-training, as well as their baseline salary and characteristics of their first job. And they then performed a quantile regression to investigate salary differences by gender, controlling for demographic factors, training characteristics, and first job characteristics, such as rural versus urban location, or academic versus non-academic site. We're going to share some of the tables from, or condensed tables from this study. So overall, there were 270 graduating residents who had accepted a first job after residency and were included in the analysis. Approximately 2/3 of these were men and approximately 1/3 were women, and about 2/3 were also graduating from 3-year programs, with the remainder graduating from 4-year programs. This table shows the factors that participants had indicated were very important in influencing their first job after residency and the differences in percentage between men and women. So factors such as parental leave policy, proximity to family, the jobs and the desired practice setting, the type of hospital, and jobs in the desired location were among those that were had significantly greater percentage of women compared to men who deemed that very important. Salary and compensation was statistically more frequently noted as being very important for men compared to women, with a difference in percentage noted here of 22%. They then looked at factors that were ranked as either very important or important for men and women in choosing their first job. And there were different priorities that were more important for women compared to men. The statistically significant ones are shown here. And the salary was deemed either very important or important to the vast majority of respondents, with the difference in percentage between men and women being attenuated here on the last row. Overall, there was also a statistically significant gender gap, even after controlling for other factors that were included on this slide in multivariable analyses, and the gap was about $30,000, with the median salary for men and for women listed here. Overall, although the authors describe how these results suggest that the reasons for gender pay gaps may not be entirely systematic and at least partly potentially related to differences in the types of jobs that are selected for men compared to women, at the same time, from our read of these results, with parental leave policy and proximity to family being among the factors that are more important for women compared to men, perhaps that suggests that systematic differences in jobs make certain jobs less tenable for women. In addition, a limitation of the study is the response rate, as is represented approximately 12% of graduating EM residents, but certainly important findings for consideration. The next study is race and sex disparities among emergency medicine chief residents. Chief resident position has, as we know, important career implications, and that at the same time, there are no consistent criteria for chief resident selection across the country. Prior studies have also noted gender disparities in chief resident selection, but have not investigated intersectionality of gender and race and ethnicity. There are also concerns for disparities when it comes to race and ethnicity in chief resident selection, given that there are racial inequities in multiple domains of undergraduate medical education, including induction into honor societies and evaluations. So the objective of this study was to describe race, ethnicity, and sex of emergency medicine chief residents and determine the association of racial identity and intersectionality of the race and sex for selecting chief residents in U.S. emergency departments. This was a nationally representative study that included U.S. emergency medicine graduates from 2017 to 2018, and the data was collected by the AWAEM and included demographic characteristics, medical school, and USMLE Step 2 scores. They then compared demographics between residents who were selected versus not selected as chief residents and performed a binomial regression to investigate the relative risk of sex, race, ethnicity, and intersectional sex and race ethnicity identity on chief resident selection while adjusting for USMLE Step 2 scores and accounting for clustering within each residency program. Just over 3,400 residents were included in this analysis, of which approximately 20% were selected as chief residents. About 2/3 of those in the study were male, and about 2/3 of the chief residents as well were male. There were also differences noted by resident race and ethnicity, as shown here. In the adjusted model, which controlled for race, ethnicity, USMLE scores, and program clustering within programs, they demonstrated that there was a sex disparity, with women being more likely to be selected as chiefs than men. And in adjusted analyses controlling for sex, USMLE scores, and program cluster, they also demonstrated a racial disparity, with Black residents being about half as likely to be selected as chiefs compared to white residents. Here we show the intersectional analysis, and overall, white women were statistically more likely to be selected as chief residents, about 1.2 times greater compared to white men, while adjusting for USMLE scores and program clusters. And URIM women had the lowest likelihood of being selected as chief residents, being about half as likely compared to white men, while adjusting for those same factors. Limitations of this paper include that the analyses couldn't account for those who may have been offered a position but chose not to accept this, and they also did not have access to other factors that could impact chief resident selection, such as evaluations or IT scores within residency, and also did not have information on the different methods that may be used to select chief residents at different programs, but nonetheless important topics for us to think about in our own departments. Our next study is on consensus-driven recommendations to support physician pregnancy, adoption, surrogacy, parental leave, and lactation in emergency medicine by the group shown here. Literature demonstrates that there's dissatisfaction with and quite a lot of variability in parental leave policies and policies that are related to pregnancy in emergency medicine. And such policies at the same time can influence recruitment, retention, and advancement of women in emergency medicine. So the authors aim to develop a consensus-driven recommendations to serve as a framework for emergency departments across the country for incorporating family-friendly policies. There were 3 main stages for developing these consensus recommendations. First, there was a working group that was formed that including members of the ASAP Wellbeing Committee as well as AWAEM, and they conducted a literature review and drafted preliminary recommendations. They then also recruited 33 key stakeholders from representatives across multiple EM organizations who then partook in voting rounds to rank those that were they believed should be in the consensus recommendations. And they determined that consensus was achieved when at least 70% of respondents considered a recommendation to be very important or extremely important. There were multiple rounds of voting and further discussion groups, and then discussion among the working group of how to incorporate the focus group feedback. And then there was also a public comment period. There's a total of 17 consensus recommendations in this paper, which I encourage you all to review after this session. So we won't be able to review all of them, but just want to speak to a few of the highlights in each category. So first, there is evidence that pregnant persons who work 2 or more night shifts per week are at increased risk of miscarriage, and they recommended that pregnant persons should be supported as they try to limit their number of night shifts. In addition, pregnant persons should also have their shifts covered in order to deal with the physical and psychological sequelae of a miscarriage. When it comes to the prepartum and peripartum period, they noted throughout these recommendations that these should be standardized policies, but that individuals should have the option to opt out of participating in these accommodations. So among these recommendations were that in the third trimester, that pregnant persons should be exempt from overnight shifts, that their schedule should also have a contingency plan in place for complications related to pregnancy, such as the onset of labor or otherwise, that patients who have presenting with TB or meningitis or a vesicular rash that's concerning for zoster should be directed towards non-pregnant healthcare providers. And when it comes to parental leave, several recommendations, including that these should really be consistent for all employees expanding their family, regardless of whether the child is birthed by that parent or acquired through adoption or surrogacy. They recommended that maternal medical leave, so what might be traditionally known as maternity leave, should be a minimum of 8 weeks of paid medical leave for the birthing parent. And that in addition, there should be an option of primary parental leave for either the birth mother or father, an adoptive or surrogate parent, and that these should be compensated for a minimum of 12 weeks under this category, and that this benefit should be ideally in addition to maternal medical leave for the birthing parent. When it comes to lactation, there are a number of recommendations to help to make this a safe and productive environment, including designating a private space that's available for pumping within the emergency department, and ideally that has a telephone or computer connected to electronic health record so that the lactating individual can be available for their clinical work as well. And that the clinical schedule should support lactating physicians, allowing for scheduled breaks from clinical coverage. There are a few limitations, of course, to this work, including that the group did not assess the feasibility of these recommendations as part of the process, as part of the consensus process, although this was discussed to some extent during the focus group. And in addition, this was a group of stakeholders and based off of review of the medical literature, but there may be cases where the best practice may not be in the literature or in the other standards that were evaluated as part of the process, and that we might need to think even more outside the box in terms of some of these criteria. So with that, I'll pass it off to Dr. Love for the remaining 2 papers.
All right, so we've got 2 more. The next study is called Where Are They Now? Attrition Rates of Emergency Medicine Residency Graduates by Gender. And so we actually know, I think it was at SAEM last year, there was a study of EM workforce attrition between 2013 and 2020 that demonstrated that female gender was associated with attrition, and female physicians who experienced attrition were significantly younger than their male counterparts. So the objective of this study was to identify a difference in attrition rates between binary genders of practicing clinical emergency physicians within 10 to 30 years after their residency graduation, so a slightly more senior group of practicing physicians. The way this was done, so the study group contacted 50 EM residency programs that were established before 2005 and requested basically an alumni list of classes who graduated before 2010. 21 programs responded and provided that list. And then the study group collected additional data from state licensing board and other websites to ascertain their state license status and hospital privileges. And then the group defined attrition as not working clinically in EM or an EM related specialty. They analyzed data from 3,725 graduates, and what they found actually was that the overall attrition rate was 5.4%, and there was no significant difference by gender. For men, the attrition rate was 5.3%, and for women, it was 5.8%. And they also found there was no difference by gender in the practice environment, so it didn't matter whether the individuals were practicing in an academic or a community setting. And in this table, you can see sort of the breakdown of those those individuals with attrition, what they fell under. So things like administration, industry, a non-emergency medicine field, and those who retired. There are some limitations to this study. So, programs that were included in this study, it was less than half the programs that they contacted, so it may not represent the entire emergency medicine workforce. An active state license does not necessarily imply active clinical work. And most of the data that they were able to source about whether or not somebody was still practicing was from publicly available sources. So obviously, there are individuals who may not be available, and that information would not be available through those public sources. They also did not contact the individuals in the attrition category to ensure that they were classified correctly. And then, sort of thinking about why this is maybe different from the Gettle study that was published. Again, this is a more senior group of physicians, and in Dr. Gettle's study, there were more recent EM graduates that were included. And so that may have played a role as to why we didn't see a difference. And then the last study we wanted to highlight is a scoping review that was done on women's professional development groups in emergency medicine. So we know that women's professional development groups like AWAEM and individual institutional groups can really help advance gender equity and support women in emergency medicine. And there are, like I said, a range of different infrastructures for these groups. And so the goal of the scoping review was to examine current women's professional development groups and create a collection of program characteristics, meeting topics, and tips for success that could be applied to either launching a new group or supporting and developing an existing group. So scoping review was conducted in 2022. It included studies with information on one or more professional development groups for female emergency medicine physicians, and they extracted data from the studies around topics such as program leadership and objectives, funding, educational initiatives, and meeting themes. And then the study group came to consensus to identify the themes around meeting topics, barriers, and suggestions. Overall, the scoping review included 11 studies that were related to 10 different professional development groups. Most common objectives of these groups were expanding networks of mentors and role models, providing career advice, leadership skills, and advancement for women, improving academic recognition, and helping with things like work-life balance. Most groups met between 4 and 10 times a year. 6 groups were based at individual institution residency programs, so they're residency derived. 40% had been funded by their departments, and 30% were working towards trying to build programming that was free or low cost in order to grow their group. Themes of the outcomes of the programs included things like increased mentorship, improved recognition, increased community, job satisfaction, and well-being. The group importantly also identified common barriers to the success of the programs and themes of suggestions on how to overcome these. So in the category of attendance, doing things like alternating day and evening activities to facilitate attendance for sort of the continuous 24/7 schedule, creating more structure to the events, and trying to schedule female residents off from their clinical responsibilities so that they could attend. In the theme of inclusion, including ensuring inclusivity by including nurses and male physicians at certain events. In the theme of in the barrier of sustainability, recruiting alumni and identifying residents and junior faculty who could carry the momentum forward. In the barrier of funding, again, planning for free events or inexpensive events or having events sponsored by attendings. And then advocating for department funds to help support a budget for some of these events. And then in the barrier of assessing impact, because we know it's always hard to assess the impact of these groups, including things like surveys and trying to develop metrics to track progress over time. So just the key takeaways from the 5 papers that we presented today. For our first paper, the median salary of the first job of graduating EM residents was $30,000 higher for men versus women. In our second study, compared to white men, Black residents, and women residents from underrepresented in medicine groups were significantly less likely to be selected as chief residents. In our third study, consensus-driven recommendations can help departments in implementing family-friendly policies. In our fourth study, the attrition rate from clinical EM did not differ significantly by gender in an older workforce. And in our last study, women's professional development groups increased mentorship, recognition, community, job satisfaction, and well-being. We want to thank the AWAEM Research Committee for their help. We had a lot of people help us review and come to consensus for these studies, as well as Melis Liston from the MGH Library, who helped with the literature search. We invite you to scan the QR code for the top 17 articles that we reviewed. And these are unranked, they're just done by alphabetical order, but these were the 17 from the past year. And we invite any questions, and we know we have some of the first authors of these papers in the audience, so we're always welcoming their feedback and their expertise from the studies we presented. Thanks for coming.